Hey, this is Doug with No Stress Training, and in the continuation of our series of videos getting you ready for ACLS, we're getting ready to talk about the tachycardia protocol. If you've got one of our workbooks or if you've got your ACLS textbook or protocols with you, it's going to be really helpful for you to have that protocol in front of you, the protocol for tachycardia. But also, it's a good idea to have a blank piece of paper so that I can give you a cheat sheet for that protocol and kind of put that protocol into context of a patient presentation and show you how to navigate this and how it flows. All right, I'm going to start right up front by telling you this is the hardest protocol, and it always has been. The tachycardia protocol has historically been a real bear. I can remember one version of ACLS when the new textbook came out and we flipped open to the tachycardia chapter. The protocol, the boxes and lines that told you what to do to treat a patient, was 8 pages long. And that was completely unworkable, and it tried to incorporate all the different factors involved in treating a patient that's tachycardic, and it was a terrible example of a protocol. But what we've done now is we've brought it back down to a single page and replaced 7 of those pages with the phrase, call a cardiologist. Calling a cardiologist is the most important thing that you can do for this patient early, because that's the physician who's the expert in the treatment of these patients. To illustrate some of the difficulties in dealing with a tachycardic patient, I want to give you kind of a scenario presentation before we even start into the protocol. I want you to imagine 2 adult patients in their mid-50s who walk into your emergency room, and from a distance, they look exactly the same. Both of them don't feel good. They're both pale, they're both diaphoretic, they're both weak, dizzy, nauseated. They're both hypotensive, and they're both tachycardic. You approach guy number 1, you say, hey, what's going on with you today? And he presents in a sinus tachycardia with a rate of 120. And he tells you, I feel awful. I've had nausea, vomiting, and diarrhea for the last 3 days. I can't keep anything down. I need to see a doctor. Now, what's wrong with him, obviously, is that he's dehydrated. He's hypovolemic. And as his blood pressure has dropped because of his fluid problems, his heart rate has come up as a compensatory mechanism. So here's a patient who is hypotensive and tachycardic, but this patient does not qualify for this protocol. This tachycardia in this patient presentation is therapeutic, beneficial, and appropriate for that patient. Now the second guy, who superficially looked the same, presents like this. He's got a different rhythm on the monitor. It's much faster, and it's difficult to distinguish the P waves. This is an SVT. The patient's history is different too. He tells you, I don't know what's wrong with me. I felt fine 45 minutes ago, and then out of the blue, I got cold and sweaty and dizzy, and I had to sit down in a chair and put my head between my knees because I thought I was going to pass out. This guy is suffering from an arrhythmia, and that arrhythmia is SVT. The problem with SVT is that it causes your blood pressure to drop because the heart is contracting so quickly that it doesn't relax long enough to fill properly with blood between contractions. Decreased diastolic fill time is causing his blood pressure to drop. So his tachycardia is the pathology that's producing his hypotension. This is the guy that this protocol was written for. So how, in an example that's not quite that stark, do you differentiate a hypotensive and tachycardic patient who's hypotensive because he's tachycardic from the one who's tachycardic because he's hypotensive? Well, one way to do that is with the heart rate itself. The tachycardia protocol in ACLS is reserved for patients who present with heart rates greater than 150. And the reason for that is because the average adult patient will tolerate tachycardias up to 150 without deterioration of their blood pressure. But when the heart rate gets above 150, the average person starts to see dips in their blood pressure caused by decreased diastolic fill time. But remember, a number is just a number. If I present to you with hypotension and tachycardia and my heart rate is, say, 154, but I'm septic, or I've got a significant GI bleed, or I'm experiencing an anaphylactic reaction, or I'm deeply hypoxic, those are all reasons for me to be tachycardic, and my tachycardia is probably a therapeutic and compensatory response to that other pathology. versus this patient here who presents with an abrupt dysrhythmia producing a drop in his blood pressure. Sometimes the trigger for this arrhythmia is known, like metabolic stress, exercise stress, emotional stress, and sometimes it's completely idiopathic. It just comes out of the blue. Once, however, you've decided that your patient has presented in a treatable tachycardia under the ACLS protocol, you have to make an immediate assessment of that patient to determine how well they're tolerating the rhythm. Patients that are tolerating these very fast rhythms poorly are called unstable. American Heart Association criteria for unstable includes profound hypotension, unconsciousness, ischemic chest pain, or organ system failure. If your patient presents with any of those or any combination of that category of symptoms, they must have their tachycardia interrupted immediately by the fastest and most efficient means possible, and that's with synchronized cardioversion. Go to the American Heart Association Protocol for Tachycardia, 2015 version, and look at the sidebar. In the sidebar on the right side of that protocol, you'll see 4 different categories of tachycardias characterized by whether they're regular, irregular, narrow complexed, or wide complexed. And with each one of those categories, they give you a range of energies that is reasonable for doing a cardioversion for that patient. Now, what I tell everyone who takes our courses is that if you do this often enough to have memorized those ranges, then use that. If your crash cart has a reference card on it and those ranges are right there immediately available to you, then use that information. But in the absence of memorization or a reference card, you don't have time to go look this up when this patient presents in this unstable emergent condition. If that's the case, it is reasonable to cardiovert that patient at 100 joules, which if you look at those ranges is in the midst of the neighborhood of the ranges of all 4 of those categories of arrhythmias. So in the lack of better information, start your cardioversion at 100 joules. Now, what does cardioversion look like? Well, cardioversion is actually a defibrillation. So what you're going to do is you're going to put the defibrillation pads on the patient's chest, and you're going to come back to your cardiac monitor and you're going to engage the synchronizer. The synchronizer is what distinguishes defibrillation from cardioversion. The synchronizer's job is to find and identify the QRS complexes in a patient's rhythm so that when you charge and shock at the appropriate energy level, the shock will not hit a T wave because it's going to aim for the QRS complex. So once again, a synchronized cardioversion is a defibrillation that is timed to the patient's EKG so that the shock will hit the QRS complex, thus missing the T wave and the dangers associated with R on T. So I come back to my cardiac monitor and I dump my energy down to 100 joules. I charge. I clear everybody just like I do for a defibrillation, and then I deliver the shock. Now, once that shock is delivered, you'll notice that we sent the patient into asystole. That's not a mistake. That was the intention of the therapy. There's a concept about your heart that says that your heart is always going to follow the rate dictated by its fastest intrinsic or extrinsic pacemaker. And in this case, this patient was suffering from an ectopic supraventricular pacemaker that was incredibly fast. And his normal pacemakers, like his sinus node, have no hope of taking over the pacemaker function from a pacemaker running at that speed. The intent of the cardioversion was to knock that tachycardic ectopic pacemaker out of commission for a fraction of a second, giving the sinus node a potential window for restoring a normal rhythm. The only thing cardioversion is capable of doing is to produce that asystolic window of opportunity which can potentially restore a normal rhythm. If your patient is unconscious, unresponsive, then sedation is not required for that cardioversion. But if your patient is conscious, then it's a good idea to sedate them before doing that. Now, cardioversion doesn't always work out the way we hope it will. I'm going to put the patient back into that very fast rhythm. They're in a clinically unstable condition. They're altered mental status, painfully responsive only, profoundly hypotensive. So I come back to the cardiac monitor and I sync. I charge to 100 joules. I clear my team, and I deliver the shock. and I again get a nice big juicy round of asystole immediately after the shock, plenty of potential for an intrinsic normal pacemaker to step in there and restore a normal rhythm, but that doesn't happen. What happens instead is that the original pathology once again overwhelms the heart's normal pacemakers and the patient remains in SVT. Now, when you step back and wonder what you should do now since the cardioversion didn't work, a lot of people will go to the protocol and say, oh, I must not have used enough energy. Let's raise the juice and shock him with more juice and maybe that'll work. That's not appropriate. The only therapeutic value that a cardioversion shock has is to produce that window of asystole. And when you did that at 100 joules and you saw that asystolic pause, that's all that shock can do. Raising the energy for that patient will have no value. What's going on with this patient is that you're now off protocol. You're going to have to consult with cardiology, or you're going to have to make a decision on behalf of that patient that's outside protocol guidelines if cardiology isn't immediately available. Now, probably what cardiology is going to advise you to do, and what's reasonable for you to do in this situation, is to bolus that patient with an antiarrhythmic medication that's appropriate to the rhythm that's presenting on the monitor, give that an appropriate time to circulate, and then try the shock again at the original level. So once again, if you can't get a hold of cardiology and you have to make a decision on behalf of this unstable patient, it is reasonable to give that patient a rhythm-appropriate antiarrhythmic medication and then try the shock again at the original level. Now, a second what if. Suppose this patient's in this SVT rhythm, they're clinically unstable, we apply the pads, I synchronize, I charge, I clear, I shock, and bam, the shock hits and the tachycardia marches straight through the shock with no asystolic pause. We failed to interrupt the rhythm. That's when the protocol allows me to up the energy. I've got to find the lowest energy level that effectively produces that asystolic interruption in the tachycardia. The protocol does not tell you how to go up in energy, it just says go up in a reasonable stepwise fashion. I have thus far been demonstrating the use of this protocol using nothing but a narrow complex regular SVT rhythm. But recognize that on my cheat sheet up here, I haven't even yet specified what the rhythm is. All we've said is that it's very fast and it's making the patient very sick. Those two criteria lead straight to cardioversion in all circumstances. That means that the rhythm doesn't have to be an SVT. It could, for example, be a wide complex tachycardia like this regular monomorphic VTAC. Patient in VTAC could be sitting there with a decent blood pressure having a conversation with you, or they could be profoundly symptomatic and satisfy the criteria for unstable. If that's the case, we synchronize. We verify synchronization by looking for markers on the QRS complexes. We charge to the same 100 joules. We clear everyone, and we deliver that shock, again hoping for an asystolic pause and hoping for a conversion in the interruption of that tachycardic rhythm. Now, there is one condition where the unstable patient with a pulse can present a real problem with this flow. And that is the patient that presents with irregular or polymorphic ventricular tachycardias. Watch what happens when I try to synchronize this unstable patient. The synchronizer is turned on, but there are no markers on top of the QRS complexes. The reason for that is because the synchronizing filter requires a repeating pattern of something that it identifies as a QRS complex. And because the pattern here is inconsistent and keeps changing because of the polymorphic nature of this ventricular tachycardia, the synchronizer is not going to work. In this situation, this unstable patient still requires a defibrillatory shock to interrupt this tachycardia. And since the synchronizer isn't going to work, I'm going to turn the synchronizer off. And in this case, I'm going to raise the energy to 200 joules and deliver an unsynchronized defibrillation to that patient. This is the one condition where you would consider delivering an unsynchronized defibrillation to a patient with a pulse, and that is a polymorphic VTAC that fails to synchronize. And in that case, it's considered to be the risk and benefit balance weighs in on the on the side of doing the shock. It's better to go ahead and give that patient that defibrillatory shock before they go into cardiac arrest than wait to defibrillate them after they are hypoxic and pulseless. All right, let's go back to this initial assessment as to whether the patient is tolerating the rhythm well or not. If the patient is tolerating the rhythm a little bit better, we call them stable. Stable is not the same thing as asymptomatic. The patient who is stable can have symptoms. They can be weak, they can feel bad, they can have palpitations, but the real key is that they've got a decent blood pressure and a decent level of consciousness. If your patient meets those criteria, then they have given you a gift, and that gift is time. And you're going to use that time to kick back and do diagnostics. The same diagnostics that we did in the bradycardia protocol. And that is a history, meds, vital sign assessment, 12 lead, labs, and cardiology consult. And again, the objective behind doing these diagnostics before treating the stable patient is that this patient may have something identifiable in this stage of diagnostics that will take you off protocol because it allows you to treat the underlying pathology that's producing the rhythm. Now, if you go through the diagnostics and you don't find anything to deter you from pursuing ACLS protocols for this patient, then the treatment protocol for this stable patient breaks into two different categories based on whether the presenting rhythm has narrow QRS tachycardias and thus is likely to be a supraventricular tachycardia, or if they've got wide QRS tachycardia, in which case there's a possibility that it's VTach. Narrow QRS tachycardias are by definition supraventricular tachycardias. They're coming from the supraventricular heart. And because the supraventricular heart is under the maintenance of the parasympathetic nervous system, the primary treatment for these patients, the least invasive, the most benign thing you can do for them is a vagal maneuver. Now, I use the word benign in association with vagal maneuvers, but everything is relative. If you do vagal maneuvers on a patient, be sure you already have a line in place and make sure your crash cart is close by. We work a lot of codes where people have keeled off the toilet without a pulse because they've vagaled themselves into cardiac arrest. There's always that potential danger. Now, that being said, there's a dozen or more ways to vagal a patient. But probably the safest way, and the way that the American Heart Association recommends, is Valsalva. And that is to ask your patient to take a deep breath and bear down against a closed glottis like they're having a bowel movement, and to hold that pressure for 20 to 30 seconds with up to 3 attempts. If you'll do Valsalva for 20 to 30 seconds per attempt and up to 3 times, studies have indicated that you can get a 25% conversion ratio with just vagal maneuvers. Now, if vagal maneuvers are not successful, you can turn to pharmacology. And the drug of choice here is adenosine. Adenosine can be given in 2 doses as needed. The first dose is at 6 milligrams and the second is at 12 milligrams. Now, if you've ever given adenosine before, you'll recognize that it's a really bizarre medication. There's several reasons why it's a very strange medication. First of all, if you give a patient a bolus of adenosine and you give it correctly, when you watch on a cardiac monitor, it often looks a lot like a synchronized cardioversion. Patients who are hit with a pharmacologically effective dose of adenosine often have profound periods of bradycardia and even asystole in their monitor, and it's done for the same reason we do cardioversion. That bradycardic pause, or that asystolic pause, breaks the rhythm of the tachycardia and gives a normal pacemaker an opportunity to restore a better rhythm. The second thing that makes adenosine an odd drug is that when you give it, within seconds of being in your bloodstream, it begins to metabolize out to an inert status. If you give adenosine slowly through a small bore hand IV, it will be pharmacologically inert by the time it hits the heart. Therefore, most hospitals will require that adenosine be given through a large bore vein, a large bore IV, a site that's close to the heart, and through some combination of 3-way stopcocks or dual lumen IV catheters that allow you to push the adenosine fast, follow it with a big saline syringe, and then raise the extremity and do everything you can to race that medication to the heart. The faster that adenosine hits the myocardial tissue, the more chance it has of being effective. All right, so that is in order for this person with stable narrow complex QRS, first diagnostics, then vagal, then adenosine 6, and then adenosine 12. What if your stable patient is in a wide complex tachycardia? You don't see this very often, but it's very possible for a patient in VTAC to be sitting there asking you what's for lunch and having a decent blood pressure. Well, for that patient, I'm going to have to put an empty box. And you're going to fill that box in. The reason there's not a specific treatment that goes there is because there's a wide range of choices that are available. The protocol, when you read it, tells you to consider a number of antiarrhythmics and interventions like catheterization and elective cardioversion, and not a single one of those medications or interventions is always the best option for every patient that presents in a wide complex tachycardic rhythm. Therefore, you're going to make a decision to fill in this box with an appropriate treatment based on a conversation with this physician and a review of these diagnostics. So, to sum up the tachycardia protocol, first of all, when a patient presents with hypotension and tachycardia, you have to first determine that the tachycardia is causing the hypotension, and you can do that with a heart rate plus the patient's clinical presentation. You must then decide whether the patient is in stable or unstable categories. If they're unstable, you must immediately progress to synchronized cardioversion. If they're stable, you progress immediately to diagnostics, and then based on whether they've got a narrow or wide complex tachycardia, follow your treatment according to that part of the protocol. All right, that being said, there are some sophistications in the protocol that are not captured by this cheat sheet. Let me give you one example of that. Let's say we have a patient who's an SVT with a heart rate of 180, and they're clinically unstable, they got a terrible blood pressure, they're altered mental status, and we know we need to do a synchronized cardioversion. Well, you turn to Dina and you said, Dina, I want you to go get the crash cart, which has got the machine on it that we're going to do the cardioversion with, and I want you to bring that back because we're going to do a cardioversion. So here she goes, and it's going to take her 4 minutes to go down the hall, unlock the closet where the crash cart is, bring that thing back, turn it on, and get it ready to go. Well, in that 4 minutes, I'm standing over this patient with a syringe of adenosine. Can I use that adenosine on this unstable patient? Absolutely, I can. Adenosine can be used in the absence of synchronized cardioversion, but what you cannot do as a team leader is you can't say, no, don't use that electrical therapy first, even though it's available, because I want to try adenosine first on this unstable patient. Part of the reason for that is because adenosine requires a brisk blood flow to work properly, and the patient who's unstable and hypotensive may not have a blood flow that's adequate to bring that medication to the heart while still pharmacologically active. Plus, statistically, cardioversion is a more effective treatment, so it is the preferred and primary treatment for the unstable patient. All right, thanks. The next protocol that we're going to talk about is going to be acute coronary syndrome.